Assalamu alaikum everyone. For those of you who don't know me, my name is Maryam Altayeb. And so today, Eman, Chaudhri, and I are going to do a PAL session in two parts. I'm going to cover the key things you guys should know for anemias, and we're going to do it as an interactive session. So it's all questions, and they're all review questions. For my end, I got them all from Ambos, but I also have extra things to show you, and, explanatory points and whatnot. But let me share this. Okay. I'm just going to share my screen here. Okay. Can you guys see the PowerPoint?
Yes, we can see.
Okay, awesome. So if you guys have any questions, like generally, just write in the chat. حتى unmute عادي. We're only 12 people, so I want it to be as interactive as possible. So today we're going to talk about anemias. So first of all, I just wanted to share this because I really wish I knew about this in third year, and I only discovered it, I think, in MSI. Osmosis has a series called Clinical Reasoning. Again, they're all on the OneDrive that you guys have for resources. Anyway, it's a lot of the pictures that I used are from that because they're very nicely illustrated, and they have all of the key topics like clinical reasoning, anemias, leukemias, lymphomas, all the key things, and not just HEM-ONC, but everything under the internal medicine folder, by the way, if you're looking for HEM-ONC. For this is the video that I referenced a lot, clinical reasoning anemias, and I linked it here. Also like BNB and that stuff. And just so you guys know, where is it? I don't know if you can still see. Okay. I'm making this table for you guys. That's basically all an overview of anemias. I just have to add like thalassemias and properly add macrocytic anemia. But again, it has like all the key things you should know highlighted. Can have my pharma table. So I just thought I'd let you guys know from now. So inshallah, by tonight, I'll finish it and send it to you guys by tomorrow. All right, so let's get a head start. So first of all, what is anemia? Anemia is low hemoglobin and hematocrit, again, for age and gender. The reason we're considering age is because the levels can be different as the person is growing. So from childhood to adulthood, fetal is different. So you need to consider the age and you need to consider the gender. So generally, anemia is defined in males as hemoglobin less than 135, but this is 13.5 if you guys see it in like the values that we use, and 120 or 12 in females. All right. And so generally, this is how we classify anemias. They can be based on the MCV, so microcytic or normocytic or macrocytic. And so this is measured in I think it's phytoliters or something, or femtoliters. I don't know the exact name of the unit, but this is how we classify anemias. And each one of these types of anemias has a different cause, as you guys know. And you can also classify it physiologically based on the reticulocytes. And so remember, reticulocytes are the new RBCs, the baby RBCs that are being pushed out of the bone marrow. So the more reticulocytes you have, the more you can think that, okay, my bone marrow is trying to push out more cells. Maybe there's a problem like a hemolytic anemia, and we'll see that in a second. So if it's less than 2%, okay, then that means in the setting of an anemia, that means the body cannot produce RBCs for one reason or another, okay? However, if it's increased, then that tells you that the bone marrow is responding adequately. And we'll see why that's important as we go through the questions. These slides I adapted from slides we have in fifth year. I think it's the same doctor that gives you guys SGDs. It was just nicely organized. So again, you can divide it pathophysiologically. If you have low reticulocytes in the setting of an anemia, maybe it's a deficiency, like iron deficiency, folate, maybe it's failure of the bone marrow, maybe it's myelodysplastic syndrome, or like metastasis to the bone marrow, something like that. If you have increased red cell production, so high reticulocytes, here you'd think of maybe hemoglobinopathy like thalassemia or something, or an acquired hemolysis. Again, these are just some examples how you divide it into microcytic, thalassemia, normocytic. Normocytic, macrocytic. But what's more important to me is this. You guys can find this chart on Ambos, and it is very, very helpful because it gives you, one, the clinical approach on how do you approach an anemia, and it categorizes the causes very nicely and cleanly. So in a microcytic anemia, we said less than 80. The key test here is going to be the ferritin. And we'll talk about this as we talk about iron deficiency anemia. But if it's low, then you know it's iron deficiency. If it's normal or high, then you can start to think of other causes, like, for example, anemia of chronic disease, thalassemia, etc. With normocytic, remember, same thing I said, what's going to be the key here is the reticulocytes. So if it's low, that means the bone marrow isn't responding for some reason. Maybe it's that you don't have erythropoietin, right, which causes your bone marrow to form RBCs. So maybe it's chronic kidney disease. Maybe they can't have, maybe their bone marrow is filled with fat. So maybe it's aplastic anemia. So it really differs. And then it can be, if you have high reticulocytes, then maybe it's hemolysis, maybe they have blood loss. So you start to, narrow your differential and you'll be able to understand what's going on in the question. Macrocytic anemias are going to show megaloblastic changes. If they do, then it's megaloblastic anemia, so folate or B12 deficiency. If not, but it's still a macrocytic anemia, then you have other causes like hypothyroidism, myeloma, reticulocytosis, other things. Okay. So now we're going to go through the actual question. So what I'm going to do, just the format of this, we're going to go through the question. I'm going to highlight the key things for you. We're going to go back to the answers and then we're going to choose. And we're going to go through the explanation. Okay. A 17-year-old girl comes to the physician because of a 4-month history of fatigue. She has not had any changes in weight. She had infectious mononucleosis 4 weeks ago. So EBV, if you guys remember from CVP. Menses occur at regular 28-day intervals and last 5 days with moderate flow. Okay. Her last menstrual period was 3 weeks ago. Her mother has Hashimoto thyroiditis. Examination shows pale conjunctiva, inflammation of the corners of the mouth, and brittle nails. Okay. The remainder of the examination shows no abnormalities. So first thing, it's a 17-year-old girl. So she's a young female. Her menstrual cycle is a bit heavy because she has moderate flow for 5 days. Okay. And on examination, she has pale conjunctiva, which is what we call pallor, inflammation of the corners of the mouth, so angular stomatitis here, and brittle nails. So now we can see, okay, she might have features of anemia. Now we got to shift our mindset to differentiating the types of anemia based on her lab results. So first of all, let's define that she has an anemia. Her hemoglobin is 10.3, which, we said the lower limit for females is 12. So this is, first of all, an anemia. MCV is 74. Can you guys tell me if that's low or high? Low. Okay. And platelet count is 280, which is normal. Normal is from 150 to 400. And leukocyte count is 6,000, which is normal. Normal is from 6,000 to 11,000, I think 5,000. So now, which of the following is the most appropriate next step in evaluating this patient's illness? I know this is a bit of an advanced question, but remember, we saw that the anemia is microcytic. And remember, I told you that most important test for microcytic anemia is what? Is the ferritin levels. So yeah, you guys got it right. So again, these are the key things. She's presenting with fatigue. She has moderate flow of her menstrual cycle. She has features of an anemia with confirmation that her hemoglobin is low. So again, these are consistent with anemia. And when you have a microcytic anemia, then you're going to do further testing. So again, just going back to this. In a microcytic anemia, ferritin is your key test that's going to differentiate between the different causes. So now let's just talk about iron deficiency anemia in general. In this scenario, they brought it to you as a 17-year-old girl, complaining of symptoms of fatigue, maybe dyspnea, maybe symptoms of pica. Remember, pica is craving for non-nutritive food substances like dirt and ice, okay? But another way it can present, which is very important for you guys to know and can definitely come in the exam, is in an older male. So this case is the case we actually got in 5th year. So 59-year-old male planned for an elective knee replacement, no other symptoms, okay? On exam, he has mild pallor, otherwise unremarkable. Routine lab, his hemoglobin is 9.9, which is very low, especially for a male. Remember, the normal for males is greater than 13.5, okay? Oops, what happened? Okay, that was weird, sorry. Okay, so hemoglobin is 9.9, which is low. MCV is 69, which is low. Remember, normal is 80 to 100. And MCH is 23, which is also low. His other labs are normal. Platelets 170, white blood cells 6. Differential count normal. Absolute reticulocytes are 18 times 10 to the power of 9. So the reticulocyte counts are low. And remember, when we think low reticulocytes, that means there's a problem with either the bone marrow or you don't have proper nutrients in order to make these RBCs. Okay, and so in this patient, it's not normal for a male to have iron deficiency anemia, especially if it's an older male. So what we're going to start thinking about is potentially GI bleed, any colorectal cancer, any other problems. So that's the key scenario here. Like they might give you these labs and then say, okay, what would be the mechanism, or what do you have to rule out? And that would be chronic blood loss through the GI. Okay. And in an iron deficiency anemia, hookworm as well is another cause. But you always need to think of colorectal cancer, especially in the vignettes that they give you guys. It's a very high yield thing. So generally, this is how iron deficiency anemia is going to present. It's a microcytic hypochromic anemia. The blood film is not diagnostic, but you can see pencil cells, which I'll show you in the next slide. Remember, low reticulocyte count. Your body is not able to make those RBCs. Low ferritin. And you need to investigate the cause. So usually GI blood loss, maybe they have an ulcer in their stomach that's bleeding over a long period of time. You guys are going to learn more about that in GI, inshallah. And in females, consider menorrhagia, or very heavy menstrual bleeding. And so the way you treat this is to replace iron. One key lab that's not mentioned here is the RDW, or red cell distribution width. And so what RDW is telling you is how different these cells are. And the very important thing about RDW is that in iron deficiency anemia, it's high. You can see how like all of the cells have different shapes, right? So these are the pencil cells, by the way. You can see teardrop cells, and you can see that there's an area of central pallor. So these are hypochromic erythrocytes. And so the reason I'm telling you that the RDW is high and that that's important is because you really need to keep in mind that, let's say you get a patient, same scenario, 17-year-old girl presenting with symptoms of fatigue, has signs of anemia, and you have your CBC shows, again, microcytic hypochromic anemia, but her RDW is normal. And let's say all of the cells look the same, then that points you more towards like a thalassemia trait than it would in iron deficiency anemia. And those two can be very confusing. So make sure you keep that in the back of your mind, that you will have normal RDW in a thalassemia, but high RDW in iron deficiency anemia. And it makes sense because thalassemia is a genetic defect. So all of the cells are going to have the same problem. It's not going to be an unequal distribution of hemoglobin. Okay, does that make sense to everyone? First case is good. And if I'm going too fast or too slow, just let me know. I just don't want to, take too much time because Eman's session is after. Okay, so I'm assuming silence is also an answer. So this is just a general overview of iron deficiency anemia. The labs are very important, and I'm going to touch upon them a bit later when we compare them to other types of anemia. But you're going to have low serum iron, okay, increased total iron binding capacity, which is basically your body's way of pushing out more proteins to bind iron, okay, and low ferritin. So ferritin is the storage form of iron. That's why I remember the question that we had is, what lab is going to be our crucial thing in evaluating a microcytic anemia? It's ferritin. Because if ferritin is low and your serum iron is low and you have a microcytic hypochromic anemia, then that points you towards iron deficiency, because it's basically telling you that your body is using up all of the iron it has in order to create these RBCs. Okay, so labs are very important. Keep that in mind. Okay, so again, chronic slow bleeding, remember, colorectal cancer, you can do fecal occult blood test. H. pylori infection, which causes an ulcer in your stomach that continues to bleed, which is, again, cause of GI blood loss, can be nutritional, as it is in, for example, that 17-year-old female, or it can be due to increased blood loss during her menstrual cycle. Pregnancy is also a cause, and inflammatory bowel disease and celiac disease, because these two things can affect the duodenum, which is where iron is absorbed. So again, if you see these things, keep that in mind. Okay. Yes, you'll also have low saturation. And I'll have a table that shows all of them, inshallah. But that's the first question. Now let's move on to the second scenario. Okay, so a 4-year-old boy is brought to the physician by his mother because of generalized weakness and difficulty walking for the past month. Lab studies show a hemoglobin concentration of 6.6, which is low for his age, MCV of 70, which is microcytic, okay, platelet count of 150,000, okay, and a total serum bilirubin concentration of 2, which is high. An MRI of the spine shows low signal intensity in all vertebral bodies and a small epidural mass compressing the spinal canal at level L1. Okay. CT scan shows osteopenia with widening of the diplopic spaces in the skull. A biopsy of the epidural mass shows erythroid colonies with an abundance of megakaryocytes and myeloid cells. Which of the following is the most likely diagnosis? What do you guys think? No. Yeah, Allah, I give you the answer. Well, yes, it's beta thalassemia. I don't like the smells. Well, okay, now you guys saw the answer, so ignore that. But anyway, the key thing here is that because this patient has likely thalassemia, what happens is there is not enough RBCs in the body, right? They have an anemia. So what happens is because they're young, they have something called extramedullary hematopoiesis. So extramedullary, meaning, outside the bones, hematopoiesis, making heme or, blood. So all of the different spaces in the body. So for example, you have widening of the diplopic spaces in the skull are what are going to cause the characteristic thalassemic facies that you see, okay? So in patients with beta thalassemia, defective hemoglobin chains results in ineffective hematopoiesis and the subsequent chronic anemia. This we already established. And because they have this anemia, the body starts reacting by trying to make more RBCs. Let's say the bones are not enough. Okay, we're going to start to use the skull. We're going to start to use other places. Okay, and as well as the skull, it can also happen in the liver, in the spleen, and in the lymph nodes. Okay, and keep in mind that this is normal during fetal development, but after birth, it's always pathological. And so these are the other options that we had. So aplastic anemia. Aplastic anemia is going to present with pancytopenia. However, this patient has a normal platelet count. Okay, so it doesn't make sense. You can't say it's aplastic because all of the cell lines would be low, not just RBCs. It's not just anemia alone, although the name might be kind of confusing. Lead poisoning is another option. It causes a sideroblastic anemia, which we can talk about later if we have time. However, it usually presents with like very vague GI and neurologic symptoms, which this patient doesn't have. And multiple myeloma could be a potential cause because you have expansion of bone spaces and all of these things. However, it does not make sense because it's very rare in children. It's very, very rare in children. So a thalassemia points us more towards there. Also, usually myeloma is going to be a macrocytic, not microcytic anemia. Okay. So let's talk about hemoglobinopathies now in general. So you're going to have low MCV and MCH, right? However, like I told you, it can be confused with thalassemia traits can be confused with iron deficiency. So keep in mind that the RDW is going to be normal in thalassemia, high in iron deficiency. And of course, if you're going to have normal iron studies because the iron is not the problem here. And it can be diagnosed prenatally. And these like thalassemia, sickle cell anemias, these things are the reason why we do a lot of genetic testing, especially in Saudi, because it's common. Because if you have, because it's recessive, right? So if you have person with thalassemia trait marries another person with thalassemia trait, you have a chance to have a baby that has thalassemia major, which can be very devastating. So you can have normal or high ferritin, and the way you diagnose is with HPLC and the HB electrophoresis. HPLC is, you guys probably had a picture in the LGTs, like the graph, and it shows, for example, if it's HBS in two places or HBA or HBF, and the percentages are going to make a very big difference in the way you deal with things. So this is the production of hemoglobin at different stages of life. Remember, extramedullary hematopoiesis is normal when the patient is, in utero, it's still developing. However, after they're born, that's when it starts to become abnormal. So you see how you have the percentage of hemoglobin F, and then as at birth, you start having, let's say, more hemoglobin F than hemoglobin A. And as the baby develops, it's going to increase until, in a normal person, all of it is going to be hemoglobin A. And you have also a small percentage of hemoglobin A2. If you have a variety in the different percentages, then you can start to think that, okay, maybe the blood is having trouble making one specific type, so you're starting to make another. And perhaps it can be due to a genetic defect, as in thalassemias. Okay. And I don't have enough time to go through all the subtypes of thalassemia with you, but what I can tell you is that inshallah they'll all be included in the table for you guys to go over as many times as you want, just because I want to cover as much ground with as many cases today. But again, so in an adult, 96%, wow, okay, 96% is hemoglobin A. And remember, you have two genes. So you have AA and beta beta, okay? And this is the normal distribution. And so when you have a defect in one or the other, it's going to alter the type of thalassemia that you have. So there's two thalassemias that we can divide into. We have alpha thalassemia and beta thalassemia. And the reason they're called alpha and beta is because we have alpha genes and beta genes, all right? So you have the degree or the amount of mutations that you have are going to dictate the severity of the patient's symptoms. So for example, you can have one loss of an alpha gene, and this patient will have no symptoms because remember here you need two alpha and two beta. So you're not going to feel that effect, right? Exactly. Thank you, Sarah. They're going to be silent carriers. However, when we start talking about the patients with thalassemia trait, okay, then we start talking about the ones that will have mild symptoms. So they have either loss of one beta, because remember you have two beta genes and four alpha. So loss of half here or loss of half here, but not both, okay? So this is going to present with mild symptoms, and generally you're not going to treat these patients, and you'll diagnose it by hemoglobin electrophoresis, like with the, chart. And however, the problem comes when we have severe disease. So severe disease, either you have alpha thalassemia major, so loss of 3 out of 4 of our alpha genes, okay, or beta thalassemia major, where you have no beta chains whatsoever. So in this scenario, the percentages that I showed here are going to be completely different, and you will see that in a second, okay? However, if you have absolutely no alpha genes, then this is going to cause death in you too. Remember how I told you that babies could be diagnosed prenatally before they're born? So this could be the scenario where you would say that, okay, this patient is going to die in utero, and they would have high drops fetalis. And treatment here is when we're actually going to start blood transfusions and iron chelating agents in order to make sure that these patients get normal blood, because the blood in their body is not adequate to supply their organs in the long term. So for example, this is a case that you might see of beta thalassemia trait. So a 25-year-old male from the Eastern Province, hemoglobin is 12.2, which is abnormal. Remember, males less than 13/13.5 is anemia. Okay, so this patient is coming for a screening and you found that they're anemic. So you did a white blood cell count with differential, okay, and these are normal, okay? However, your RCC is slightly elevated, your MCV is low, it's less than 80, okay? Your MCH is also low, okay? But the key thing here is that our A2 is elevated, okay? It's more than normal. And so 90% of these patients with the beta thalassemia trait will have low red cell indices, but this patient is presenting, for example, asymptomatically or with very mild symptoms. Okay, and so this HPLC of A2 4.5 that you see on that graph is what's going to tell you that there is a problem. But remember, key thing, when you see a microcytic anemia, you're going to look at the ferritin. And ferritin here is within the normal range. It's 128. So it tells you that, okay, this patient has a microcytic hypochromic anemia. However, it's not likely to be iron deficiency because my ferritin is normal. It's not likely to be anemia of chronic disease either because he does not have a chronic disease, simply put. Okay. And so another case of a couple. So this is a male that's 28 and a female that is 23. So again, we found that the male was anemic and the female was also very anemic, okay? And MCV, MCH are low for both of them, okay? And reticulocytes are increased in the male, decreased in the female. What matters here is the A2 percentage, okay? So here it's 2.2, here it's 3. And however, here you could occasionally see HBH, okay? So what we look at in this scenario is that this patient has alpha thalassemia trait, okay? And in this patient, on the other hand, her ferritin is low, okay? So we're most likely pointing towards iron deficiency anemia, not athalassemia in this patient, okay? And as well as, her A2 being normal. But the key thing here is that when you're doing screening, like premarital screening for a couple, although you're assuming that this patient has iron deficiency anemia, you're still going to do your HPLC, you're still going to do your electrophoresis to check whether or not she's a carrier. Because let's say you have this male with alpha thalassemia trait, and let's say hypothetically this female has beta thalassemia. هندخل في مصيبة. It's going to be a huge problem for the baby because it's going to be born with thalassemia. Not 100%, of course, you have to do like the Punnett square to see the percentages. However, it is a very dangerous scenario, okay? So just keep that in mind. You cannot 100% exclude thalassemia trait in these cases, but it's important to understand the differences and the impact of having two patients with the same disease, or like, you know, thalassemia alpha and beta. Because remember from the graph that I showed you, this one, you can still have both. You know, for example, if you have alpha thalassemia trait, and then you have okay, let's say this person, okay, and this person have a baby, you could get a scenario where the patient has a very severe disease, which is dangerous, of course. Okay, and so this is a patient with beta thalassemia major. Okay, however, this is post blood transfusion, so that's why you see abnormal cells that are hypochromic along with normal cells. These normal cells are from the blood transfusion, so from the donor, not from the patient themselves. And I don't think I mentioned this to you guys, but okay, so you know how the treatment is blood transfusions and then iron chelating agents? The reason we're giving them iron chelating agents is because when you give someone iron, there's no way for you to get rid of it unless you're a female through, you know, menstrual bleeding regularly. So they give them iron chelating agents to prevent iron toxicity in the body. I don't know. I didn't mention that, but I thought it would, you know, be good for you guys to know. Okay, and for example, we said there's HPH seen in the other patient. So you do a supravital stain, which remember usually used for reticulocytes to see those tiny inclusions. But in HPH disease, this is what it's going to look like. It has like a golf ball appearance, as they call it. And it's just the supravital stain binding to these RBCs. Okay, I don't know if you guys had that in the lecture, but I just thought it would be good to include as well. So now, before we go on, do you guys have any questions regarding thalassemias? Or is it clear? Clear? Inshallah, easy. But remember, if you see a child with, you know, thalassemic facies, start to think of that. If you see normal RDW, start to think of thalassemias. Okay, so now we have a new case, and I actually really like this question. Okay, so a 55-year-old woman with rheumatoid arthritis comes to the physician because of a 3-month history of worsening fatigue and dyspnea. She has felt short of breath when walking up the stairs to her apartment. Menopause occurred 5 years ago. So why is this important that menopause occurred 5 years ago? It makes iron deficiency anemia less likely of a cause. Okay. Her medications are methotrexate and folic acid supplementation. Physical examination shows conjunctival pallor, tenderness of the bilateral wrists and knees, which is normal finding in patients with rheumatoid arthritis, as well as ulnar deviation of the fingers. Hematocrit is 27%, which is low. MCV is 84, which is normal. And serum ferritin is 475 nanograms per milliliter, which is high. Okay. Which of the following has most likely contributed to the patient's symptoms? So now let's dissect the question that you guys already got. Okay. So if we focus on the key elements here, she has rheumatoid arthritis, which is a chronic disease. She's presenting with symptoms of anemia with low hematocrit, okay? And her MCV is normal and her ferritin is high. So this is anemia of chronic disease. So another way of asking this question, instead of giving you a long vignette, is what is the mechanism of anemia of chronic disease? What is the pathophysiology? So what we can say for that is, Owen, you guys did amazing. You're 100% right. It is increased release of hepcidin by hepatocytes. So what is hepcidin and why does this happen? So this is the, you know, general overview of the iron metabolism. And so hepcidin is an acute phase reactant, but it is an inhibitory protein, let's say, or inhibitory molecule. And so the reason we have hepcidin in the body, subhanAllah, and the reason it increases in cases of inflammation is what it does is it stops your macrophages from releasing the iron. It kind of traps them inside like a cage. And subhanAllah, in states of inflammation, iron is considered a source of nutrition for, you know, bacteria. Let's say if you have a case of sepsis or a flu or anything. And so it's a natural mechanism in the body by which the hepcidin is going to trap the iron inside the cells so that the rest of the body can't use it. Okay. However, in anemia of chronic disease, it's not like they have the flu and it went. It's a chronic disease. It happens consistently. So the iron is always trapped inside the macrophages, okay, inside the liver, and it's not able to be released, so the body cannot utilize it. So that's what this is saying here. So hepcidin is an acute phase reactant, meaning it increases in inflammation with IL-1 and IL-6, and it is released by hepatocytes in response to activation of iron-sensing proteins. So hepcidin synthesis, like I said, is increased in states of inflammation or high transferrin bound levels. So that's iron overload, but that's not the objective of this question. Okay, and decreased in okay. Basically, what it does is it regulates the iron metabolism. And here you go. Hepcidin inhibits the absorption of iron from duodenal enterocytes into the bloodstream and iron release from macrophages. So it's preventing you from absorbing the iron, and it's also preventing the macrophages from releasing the iron. So in chronic inflammatory conditions like specific cancers, lymphomas, rheumatoid arthritis, this is a chronic state of inflammation for these patients. So it's going to cause their labs to be like that for an extended period of time. So this is, again, a similar scenario to what we just saw. And this is how it's generally going to present. 55-year-old female, for example, non-hypertension, rheumatoid arthritis, MCV is normal. Reticulocyte count is, upper limit of normal. White blood cells are normal, normal differential, normal platelets. ESR or CRP are going to be high, which are inflammatory markers. So C-reactive protein and erythrocyte sedimentation rate are going to be increased. So basically what you're going to see is a normocytic, normochromic anemia with normal white blood cells and normal platelets. And the ferritin here is going to be normal or high. Remember, ferritin is going to help us differentiate between anemia of chronic disease and iron deficiency anemia. But the important thing for you guys to know is that anemia of chronic disease can be microcytic or macrocytic. However, in 75% of the cases, it is a normocytic or microcytic, not macrocytic, ignore that. So anemia of chronic disease is either normocytic, so the cells appear normal, so within 80 to 100, or microcytic. They're normocytic in 75% of the cases, okay, and they're microcytic in 25. So most likely in a question, they will bring it to you as a normocytic anemia. How do you like this? Same scenario as this, or as like the one we saw in this question, okay? But just, so you know that it can be both, not just one or the other. So again, chronic inflammatory diseases, infections, autoimmune disorders, cancers are going to lead to this state in general. And the way you treat it is by treating the underlying condition, because it's going to prevent the inflammation and, decrease the hepcidin, and everything is going to resolve from there. But the important thing is that serum iron is low because you can't release it, right? Decreased TIBC, decreased total iron binding capacity, because you don't need to bind iron, right? You're in a state of inflammation. But remember, your ferritin is going to be increased. So that's the key thing. So again, in the table that I'm going to send you guys, I have this sub-table because it's very important for you guys to differentiate. So iron, TIBC, ferritin, percent saturation, and reticulocytes are very important when you're looking at a CBC, right? And when you're doing iron studies in order to differentiate the various causes of anemia. So this is just, a visual representation so that you know in each type of anemia what happens. Sideroblastic anemia, I put in like the extra slides. So if you guys want to learn more about it, it's there. I don't know if they gave it to you in a lot of detail, because I remember for our HEM, well, our HEM went by so fast, I don't remember a lot of things. But so serum iron in iron deficiency and anemia of chronic disease is going to be low, okay? However, in iron deficiency, total iron binding capacity is high, right? Because your body's trying to grab onto more iron, okay? In anemia of chronic disease, it's going to be decreased because your body's in a state of inflammation. It doesn't want to bind more iron for the bacteria to use, right? Ferritin, on the other hand, in iron deficiency is low, remember, because this is the storage form of iron. And this is the very key differentiating factor. Iron deficiency has low serum ferritin. Chronic disease or anemia of chronic disease has high serum ferritin. And percent saturation in chronic disease is normal, but percent saturation in iron deficiency is low. And for all of them, your reticulocyte count is going to be low because you're not able to utilize that iron to make the various, RBCs. Is that clear to everyone? Wallah, don't look at the answer, please. Yes? Promise? Inshallah. Okay. I think inshallah we'll be able to finish all the questions today. But if you guys have any questions, just write them in the chat already. So now we move on. A 45-year-old woman comes to the physician because of a 2-week history of painful ulcers in her mouth. Over the past 2 months, she has had increasing fatigue and difficulties concentrating. She has a history of rheumatoid arthritis, again, okay, and was started on a new medication 4 months ago. Examination shows mucosal pallor and 3 tender ulcerative lesions in her mouth. Her hemoglobin is 8.7, so she's anemic. Her MCV is 109, which is high. Blood smear shows hypersegmented neutrophils. Which of the following is most likely the cause of this patient's finding? So I want you guys to, look at this and let me know. I'll give you a minute. Because remember, she has rheumatoid arthritis, but what's more important is that you look at her lab values and tell me what you think. Okay, صح وليد, it's a macrocytic anemia. The macrocytic anemia with hypersegmented neutrophils. So it's a megaloblastic anemia. So what are the 2 causes of megaloblastic anemia that we know? Folate, B12. Okay, so the key thing in this question, I know it's a bit confusing because I just told you rheumatoid arthritis causes anemia of chronic disease, and I completely agree. But we said anemia of chronic disease is either microcytic or normocytic. However, this patient is presenting with a macrocytic anemia. So now it's different. They just put rheumatoid arthritis to confuse you. Okay? Something is wrong with DNA synthesis, 100% true. So now, because the MCV is high, we know it's a macrocytic anemia. And you have hypersegmented neutrophils, so that says megaloblastic. So it's basically asking, which of the following is the mechanism of megaloblastic anemias? If I ask it in that way, what would you guys choose? A, B, C, D, E, or F? Okay, this was actually, I think a 4-hammer question, if I'm not wrong. I like none of the above. Unfortunately, that's not an option in AMBOSS. The answer is deficient nitrogenous base production. So basically what happens in megaloblastic anemia is you either don't have folate or you don't have B12, but those are important to synthesize your nitrogenous bases, okay? Remember, those are necessary for DNA synthesis. Okay, so you're right, something to do with the DNA, but specifically what it is DNA synthesis of your nitrogenous bases. So in this scenario, this patient, I know this is more high yield than what you guys should know, but it was in rheumatoid arthritis, you give them a drug called methotrexate, and it usually causes a vitamin B9 deficiency, okay, which is folate. So what happens is when you have a folate deficiency, you have impaired DNA synthesis, same thing with B12, okay, which leads to megaloblastic erythropoiesis and the megaloblastic changes. So you can see on the, I think you guys can see it here. So you know how you have basically more than 5 lobes in your neutrophil, which makes it a hypersegmented neutrophil. So the reason that's the case is because it keeps trying to divide and keeps trying to make more DNA, but it can't because the vitamins are not there in the first place. There's a deficiency. So this is generally the mechanism. However, there are other options that people chose a lot, and they're very important for us to go through in order to understand why they're wrong. So deficient heme synthesis or deficient DNA crosslink repair. So if you have a DNA crosslink repair defect, that's something called Fanconi anemia, where they have pancytopenia in all their cell lines, short stature, cafe au lait spots, all of these different malformations. They also have increased incidence of AML, which Eman's going to talk about later. But this is not the mechanism. It's not DNA crosslink because by elimination, if you're looking at all the options here, your problem is not repairing the DNA. Your problem is that you can't make it in the first place, which is why you get the megaloblastic anemia and the megaloblastic changes. Okay. And so the other option was deficient heme synthesis. So in deficient heme synthesis, that's what we call sideroblastic anemia that can be caused by vitamin B6 deficiency. Okay, and the general scenario they might give you for this is if they have a patient that's on isoniazid or INH treatment for tuberculosis. You guys took TB already, so this is not a new drug, but here you might have, anisocytosis change in your cells, but you won't have hypersegmented neutrophils. Sideroblastic anemia presents differently. It presents with, it's one of the causes is lead poisoning. So you might have, generalized malaise and these symptoms, but your anemia is usually microcytic. Okay. So again, this is a general scenario of megaloblastic anemia. However, instead of a rheumatoid arthritis patient, this patient has Crohn's disease. So Crohn's disease with ileal resection. So you guys know that I have a slide for this. Okay, I'm sorry, the slide is later. You guys know in megaloblastic anemias, let's say for B12. B12, you're going to eat the food, it's going to go into your stomach. Okay, you have intrinsic factor released by your parietal cells. It's going to bind the B12 until it's going to go down to the ileum, and at the ileum, it's going to get absorbed. But you can't do that if you don't have your intrinsic factor, and you can't do that if you don't have an ileum. And with Crohn's disease, it usually tends to affect the ileum. So if they tell you in the scenario, this patient had an ileal resection, or they literally took out her ileum because the inflammation was there for a long amount of time, and they show you this type of picture: low hemoglobin, high MCV, okay, reticulocytes are low, no abnormalities on blood film, okay, or just hypersegmented neutrophils, for example. Here you know that this is a megaloblastic anemia, and most likely B12 deficiency because of this scenario, okay? So then you would go measure the B12 levels and give them B12, okay? And you could also see the scenario if a patient had a gastrectomy, if they removed their stomach, okay, or they had a sleeve. So what happens there is that there's no intrinsic factor. The ileum is okay, but the intrinsic factor isn't there to be, to absorb the B12 later. All right, so this is what you'll see. This is what I was trying to show you. This is the hypersegmented neutrophil. So you can count 1, 2, 3, 4, 5, 6, 7, etc., etc. There are more than 5, okay? And if you do a bone marrow aspirate, these are the types of cells that you can see. You can see how it's starting to form many lobes. All right. And so when we look at our macrocytic anemias, remember, greater than 100, on the blood smear, they can be megaloblastic or non-megaloblastic. So megaloblastic is what we just talked about. Non-megaloblastic, we'll talk about in a second. But we have one more question that's very crucial for you guys to know, especially with this, and can definitely and easily come in your exam. So this is a 54-year-old man, comes to the physician because of generalized fatigue and numbness of his legs and toes for the past 5 months. He has hypertension and hypercholesterolemia. He underwent a partial gastrectomy for peptic ulcer disease 15 years ago. Key thing, remember. He's a painter. Current medications include amlodipine and atorvastatin. His temperature is 37, pulse is a bit high, respirations are normal, blood pressure is normal. Examination shows conjunctival pallor and glossitis. So glossitis you can specifically see in megaloblastic anemias. You guys got it, but I'm going to continue reading the question for the recording, okay? Sensation to vibration and position is absent over the lower extremities. He has a broad-based gait. Patient sways when he stands with his feet together and closes his eyes. Do you guys know the name of this test when you ask them to close their eyes and stand with their feet together? If not, Adi. Yes, okay. Romberg test, you're right. Okay, so this patient has his hemoglobin is 10.1, which is anemic. Leukocyte is, I think, a bit low or borderline, and platelets are low. Okay, so everything is low. Tamam. Which of the following laboratory findings is most likely to be seen in this patient? So, like you guys correctly said, this patient has vitamin B12 deficiency and subacute combined degeneration. How do we know that? We know that because of the neurologic symptoms he's presenting with. The broad-based gait, positive Romberg test, loss of vibration and proprioception, okay, as well as the pallor and the glossitis. So the key thing here is that in these types of anemias, you're going to have an elevated level of methylmalonic acid, or MMA, okay? And the reason why is because vitamin B12 is a key coenzyme in methylmalonyl-CoA mutase, okay? So if you have low B12, okay, it's better to explain here. So vitamin B12 is important here in methylmalonyl-CoA mutase, okay? Vitamin B9 is also important, but in an earlier step, okay? And so if you don't have vitamin B12, basically you cannot convert your methylmalonyl-CoA into your succinyl-CoA. And what's going to happen is this is going to build up. So you're going to have high methylmalonic acid levels. And the reason this is important is because it's a very key differentiating factor between vitamin B12 and vitamin B9 deficiency. Okay, although they're both going to be megaloblastic anemias, it's very important for you guys to keep that in mind. Vitamin B6 is also an important cofactor, again, in heme biosynthesis. So this is going to cause a sideroblastic anemia, but we're not talking about that here specifically. So again, we know megaloblastic anemia is impaired DNA synthesis, right, of our nucleotides, like we saw in the last question. And so you're going to see a hyperlobulated neutrophil. And however, the difference is in vitamin B12, you're going to have increased homocysteine. Same thing in folate, increased homocysteine because of the whole pathway that I'm not going to go into because, again, we don't have enough time. But the key thing here is that you need to differentiate. In vitamin B12 deficiency, methylmalonic acid is going to be high. In folic acid deficiency, it's going to be normal. Okay, so I just used to remember that for folate, the methylmalonic acid is fine, like FF. Okay, and in B12, it is elevated. Okay, so just keep that in mind. So these are the general symptoms. So like you guys saw, neurologic symptoms. Okay, for vitamin B12 deficiency, subacute combined degeneration. And so sometimes it can be anti-intrinsic factor antibodies. Remember, we said intrinsic factor is the edema in the stomach. Okay, so let's say you have a gastrectomy, could also be you have antibodies against your parietal cells. Okay, it could be because of Crohn's disease, ileal resection, like I told you. Okay, and treatment, you can give oral B12, but be smart about it. If the patient had a gastrectomy, they don't have the intrinsic factor. Can you treat them with oral B12? It's going to do nothing. So what you do in this scenario is you'd give them IM, intramuscular B12. Okay. Folic acid deficiency will present without the neurologic symptoms, but will be a megaloblastic anemia nonetheless. And usually you can see it in patients with very restricted diet and pregnant women. Okay, and here you just treat them with oral folate. Also, another cause of vitamin B12 deficiency is very strict vegan diets. So keep that in mind because you get it from meat. So if you don't eat the meat, you won't get the B12. All right. So again, this is just telling you what I was telling you. So you have the parietal cells that are making the intrinsic factor. Either you have a gastric bypass or a full gastrectomy, no parietal cells. Okay, what if you had a pernicious anemia, which is the anemia where you have IgA targeting the intrinsic factor or the parietal cells? Again, you won't have intrinsic factor. Or you have Crohn's disease that damages the terminal ileum, which is where you absorb your B12. You know, so these are just the different causes. So you guys have a nice mind map of what can the scenario come as for a patient with B12 deficiency. Again, the symptoms are going to be like the ones we saw. Positive Romberg test, loss of vibration and proprioception, you know, the features of subacute combined degeneration. Now, I told you there's megaloblastic and non-megaloblastic. Non-megaloblastic anemias have various causes. So either chronic alcohol that can lead to liver disease, hypothyroidism, myelodysplastic syndrome. So these are just the other causes of non-megaloblastic anemia. Okay, so again, macrocytosis. However, you won't have DNA replication problems, okay? Because it's not a vitamin problem. It's just, you know, another problem within the body. And again, the treatment for this is just you assess the underlying disease. But again, what's most high yield is that you guys know that methylmalonic acid is high in vitamin B12, normal in folate, okay? And that the problem is a problem with DNA synthesis, specifically the nucleotide bases, okay? Everything clear? I'm assuming, yes, okay. Yeah, we just have a couple more questions. I want to get through as many as possible with you guys, because this is, again, another key thing. So a 30-year-old man comes to the ER because of a 2-hour history of back pain. Yesterday, he noticed that his eyes started appearing yellowish, so that's very important, and that his urine was darker than normal. Okay, 3 days ago, he was diagnosed with tuberculosis and started on isoniazid. That's important. So new start of a medication. He worked as a plumber for the last 5 years. Temperature is normal, vitally stable, everything is normal, okay? Examination shows back tenderness and scleral icterus. Lab studies show hematocrit is low, leukocytes are normal, platelets are normal, okay? And this is very important, okay? So his bilirubin is high, it's greater than 1, okay? And his direct is 0.7, meaning the indirect is 3.3, which is high, okay? Haptoglobin is low. Lactate dehydrogenase is high. In the urine, you can see blood, protein, RBCs, and WBCs. So which of the following is the most likely underlying cause of this patient's anemia? Okay, just give me your answer, and I'll let you know. Or, okay, tell me, what do you think the diagnosis is? Again, it's a scenario of a patient who's coming, starting a new medication, suddenly has symptoms of jaundice, so has symptoms of a hemolytic anemia. So yes, you guys are right. So this is a G6PD deficiency, okay? And so again, this patient presents with features of hemolytic anemia, which is high unconjugated, remember that, unconjugated or indirect hyperbilirubinemia, low haptoglobin, high LDH, and has evidence of intravascular hemolysis, okay? Which is the hemoglobinuria. So there's, blood in the urine. So recent intake of isoniazid indicates the cause of this patient's hemolysis. So another way of asking it is, what is the mechanism by which G6PD deficiency occurs? Or why do they have hemolysis? It's because of an absence of reduced glutathione. So basically what happens in these patients is they lack an enzyme, okay, which helps with the pentose phosphate pathway. And we need NADPH. The reason we need NADPH, which is basically here, it's going to help replenish our glutathione stores. And the reason we care about our glutathione stores is because the more we have them, okay, the more we're able to fight off stressors in the body, whether those stressors are drugs, whether those stressors are infections, okay? So that's just the most important thing here. And it's most common in African, Mediterranean, or Asian descent, okay? It's X-linked recessive in inheritance, so it affects males more than females. So if you saw the scenario, it's a 30-year-old man, which gives you a clue here, okay? Because you know how males have one X, one Y. So if it's a recessive disease and they only get the damaged X, then khalas, they get the disease. But for females, we have two, right? So if one is damaged, the other one is fine. Unless both of them, you inherit both, which is rare. So you have increased states of oxidative stress trigger a hemolytic crisis. Okay, and again, the hemolytic crisis basically means you have your red blood cells breaking down. Because they're breaking down, you're releasing heme, right? You're releasing the whole hemoglobin, you're releasing your LDH, okay? You're releasing everything, okay? And so the breakdown of hemoglobin, okay, is going to cause a hyperbilirubinemia indirect, right? Because it's all like bursting at once. The liver does not have time to process it all, okay? And so very important. So it can be caused by fava beans, which is why it's called favism, okay? Isoniazid treatment, as in this case, sulfa drugs, okay? And specifically bacterial and viral infections, all right? So that's for G6PD, type of hemolytic anemia. So again, oxidative stressors are going to cause hemolysis of the RBCs. It's X-linked recessive, and you'll diagnose it by G6PD levels. On your peripheral blood smear, you can see bite cells, which are these that have like a bite taken out of them, and Heinz bodies. So it's just because the blood cells don't have enough time to mature. You treat them by avoiding the triggers and preventing by, treat them with a blood transfusion if they're very symptomatic, and prevent it by avoiding the triggers, okay? So that's G6PD. Which region is it more common in? Again, it depends on the variant. So you have Mediterranean variant, which tends to be very severe, which is what we can see. And you also have a milder variant in African descent. Where is it more common specifically? I'm not sure. Where in Saudi exactly? I can't pinpoint the areas to you, but I'll look it up and let you guys know if you're actually interested later. Okay, so that's G6PD. Again, you can see the bite cells, you can see these Heinz bodies. Those are the key characteristic features, all right? And this is what you're going to see in hemolysis, whether acquired or hereditary. High LDH, low haptoglobin, which is very high yield. So what haptoglobin is basically in your red blood cells, right? You have your hemoglobin. So you have the heme, you have the globin, you have the iron. So when all of this is released, something needs to bind the iron, which is going to be the haptoglobin. Okay, and so that's why it's going to be lower than normal. LDH is released from the cell, so it's high, and your bilirubin is high. And remember, it's an indirect hyperbilirubinemia, not the direct, or unconjugated is more than conjugated. And so this is why they get the features of jaundice. They get yellowing of the skin, yellowing of the sclera, or what we call scleral icterus, and the blood smear will show abnormal RBCs. Okay, so now we move on to the next question, which is kind of related, but you guys are going to have to come up with a diagnosis. Okay, 21-year-old man, so younger patient, comes to the physician because of a 3-day history of yellowing of his eyes, so jaundice. He noticed a decrease in his exercise capacity and gets quickly exhausted after minor physical activity. Examination shows scleral icterus and pale mucous membranes. He has splenomegaly. Hemoglobin concentration is low. He's anemic. Leukocytes are normal, platelets are normal. Direct antiglobulin and heterophile antibody tests are positive. Which of the following abnormalities are most likely present in this patient? What do you guys think? Okay, yeah. You guys are all getting it. So yeah, this is decreased haptoglobin. It's the exact same thing as the previous scenario. So it's a form of acquired hemolytic anemia. But remember, the diagnosis of hemolytic anemia is going to be the same. The difference here is that your direct antiglobulin and heterophile antibody tests are positive. So heterophile antibody is going to be positive in infectious mononucleosis or EBV. Okay, and EBV is one of the causes of cold agglutinin disease. Okay, so what happens is it's a specific type of autoimmune hemolytic anemia. However, in this type, you're going to have IgM antibodies positive. Okay, and it's called cold agglutinin disease. You'll see in the next couple of slides, they basically stick together. Okay, and this is a cold hemolytic anemia. You also have warm hemolytic anemias. Okay, so again, because this patient has hemolysis, they're going to have low haptoglobin. But the key distractor in this question here is that you have increased direct to total bilirubin ratio. That's not true. Remember, I told you it's an indirect or unconjugated hyperbilirubinemia, right? So because of that, this is not the right answer. So they might put this in a question to confuse you, but just keep that in mind, okay? So you're going to have increased indirect to total bilirubin ratio. All right? Is the whole picture of hemolysis clear for everyone? Yep. Okay, awesome. So again, this is autoimmune hemolytic anemia. The key thing that they might tell you is that you'll see spherocytes. And you might think, okay, spherocytes, hereditary spherocytosis. But it doesn't necessarily have to be the case, okay? So basically, like I told you, oh, okay, 1 second, sorry. Like I told you, you're going to see typical findings. So decreased haptoglobin, high LDH, high indirect bilirubin, and peripheral blood smear abnormalities. So you can see schistocytes, spherocytes as well, but spherocytes in the case of usually autoimmune hemolytic anemias. Okay, so remember, there's a mnemonic, 2 mnemonics on AMBOSS. So warm weather is great. So remember, warm hemolytic anemias are caused by IgG. And cold hemolytic anemias are IgM. So you can see them in cases of malignancy, mycoplasma pneumoniae, and mononucleosis. Okay. And so this is what I told you guys. This is, you see how they're clumping together? So this is cold hemolytic anemia. And this is what you can see in like a warm hemolytic anemia. Okay, so you can see the reticulations in the cells. And again, just so you have them in mind, you can also see spherocytes in hereditary spherocytosis, where you have defects in anchor and spectrin or band 3, and diagnose them by Coombs test, okay? But you have to rule out autoimmune hemolytic anemia, and the diagnosis for hereditary spherocytosis is osmotic fragility. Okay, so this is, Eman, this is the last question. Okay, so Coombs test will be negative in hereditary spherocytosis. Yeah, because there are no antibodies binding to it. So what you do is osmotic fragility. Like what this is saying is that the reason you do a Coombs test is to rule out autoimmune hemolytic anemia because you can see spherocytes in them, okay? Easy, inshallah. Okay, so yeah, like last question. And I have more cases for you later if you want to go through them on your own time with lots of pictures. So yeah, okay. 7-year-old girl is brought to the physician by her mother because of a 5-day history of fever, fatigue, and red spots on her body. Temperature is elevated, pulse is high, blood pressure is normal. Examination shows pallor, petechiae, and a maculopapular rash over the trunk and extremities. Laboratory studies show hemoglobin concentration of 7, which is low, leukocyte count of 2,000, which is very low, platelet count of 40,000, which is also very low, and reticulocyte count of 0.2%, which is also very low, considering that the patient has an anemia. Okay, so peripheral blood smear shows normocytic normochromic cells. Bone marrow aspirate shows hypercellularity. What is the most likely cause? Yep, okay, you guys got it. So this is an aplastic anemia. So remember, in an aplastic anemia, everything is low. You have pancytopenia, plus the patient has a low reticulocyte count. Remember, in a patient with a hemolytic anemia, you're going to see high reticulocytes, more than 2%, because the body is responding appropriately to the anemia. You're breaking down the cells, okay, we'll give you more. Okay. And so in this case, the reticulocyte count is inappropriately low, which tells you that the body is not responding properly. And in the setting of a pancytopenia, pushes you towards making the diagnosis of an aplastic anemia. Okay, so you have various causes. It can be drugs, it can be radiation, it can be congenital conditions like Fanconi anemia. It doesn't have an age range, but you have, for example, Fanconi anemia and Schwarzman-Diamond syndrome, where these can present in younger ages. It can also be due to malignancy. So there isn't a specific age where you'll see it. But for example, in children that have parvovirus B19 infection, it's a very known cause that they can have of aplastic anemia subsequently after that. Also EBV, CMV. So there are various causes of aplastic anemia. So this is like a mnemonic for the agents that can cause it. So can't make new blood cells properly. So these are the different drugs that can cause it, and this is what you'll see. So how to differentiate between A and D. Wait, let me go back. A and D, idiopathic thrombocytopenic purpura. Okay, so ITP is going to present a bit differently. These are more cases for your own personal review, but wait. One of these cases is ITP, just so I can show you Miran. This is a myeloma case. And this is microangiopathic. It's somewhere here. I'll find it and let you know. But basically, the way that that's going to present is going to be different in the sense that in an ITP, you're going to have, okay, it's going to be thrombocytopenic and you're going to have purpura. But remember, it's idiopathic. Okay, so you're not going to have a clear history of these different causes, like a patient on methimazole or carbamazepine or chloramphenicol or had a recent infection, and it's going to be more direct in that sense. And when you do a bone marrow biopsy, it won't show acellularity. And like you mentioned, ITP would have normal PT and APTTT and no hemolytic anemia. Because in children, it's also after infection, right, too. I mean, it can be, but from what I remember, this is generally the presentation. And I don't think they'll ask you guys in that sense because that's more pediatrics than it is HEM-ONC. But I'll find like a very specific answer for you and let you know. So again, this is just, well, Eman, I'm done. I'm sorry. This is just a general overview. Remember, microcytic, do your ferritin, and remember the differences in the values. Normocytic, if it's hemolytic, look at the presentation of jaundice. And look at the reticulocyte count. Is the body responding appropriately or not? Macrocytic is going to be DNA, right? So megaloblastic, vitamin B12, subacute combined degeneration. Folate is going to be vitamin B9 problem. Okay, and you have other non-megaloblastic causes. So I think we can stay on the same one, but if you want to. So again, I added more cases for you guys. So what do you want to do next? This is like warm. There's multiple myeloma. You can see like the Rolo formation. Plasma cells in the bone marrow, etc., etc. There's also microangiopathic hemolytic anemia case, TTP, and I also included like morphology. So this is hereditary elliptocytosis, spherocytosis, sickle cell, which is very important. Like I added summaries from osmosis again for you guys. Again, go through sickle cell really well. Remember, the way hydroxyurea works is by increasing hemoglobin F. They can ask you that as well. Okay, and the complications, vaso-occlusive crises, malaria. Eman, I'm done if you want to go. This is sideroblastic anemia. If you guys, do you want to connect your laptop?
Yeah,
Okay,
because you need your laptop to study, right?
I do need my laptop to study. Tabila, guys, we're gonna let Eman join. There's also myelofibrosis. Yeah, teardrop cells. Good one. But inshallah, you guys got this. And do you have any questions while like Eman is setting up? You want to set up?
Yeah.
Do you want to do it? You're welcome. Inshallah was helpful. And inshallah, like in the best way possible, يا رب الأسئلة اللي جبتها تجيكم. Can you get them right? And please get them right. You're welcome. أهلا وسهلا, you guys. Okay.
Okay.
تعالي we plug in your laptop. And we switch. Yalla, signing off. You guys are gonna see Eman in like 2 minutes. Bye, guys. Wait, I want to just fix
Don't
your.
talk smack about my laptop.
I will.
She's old. Just give me 1 second, guys. Sorry,
I'm
the
just
mouse is not
connecting her
working.
mouse.
We're gonna need until 7:05 if that's okay. Just because it's already 6:11.
Okay, connect. Okay, now the mouse is working.
Okay.
Is it working? Yeah, it is working.
Oh, amazing. Thank you.
Oh,
Alrighty. Hi, guys.
pay attention, you guys.
How are you all today?
What's yours?
I'm gonna assume you're good. Okay, awesome. Awesome. I know HEM-ONC tends to be a pretty short block, and learning like we're not using the mouse. Okay. No, it's overwhelming. Okay, just give me 1 second, guys. I'm gonna open up the questions and I'm gonna put them up here, okay? But in the meantime, I just wanted to tell you guys, I want to ask you, how has it been so far learning the lymphomas and leukemias? Because I do hear, like, even in like the 10th batch when they were doing it, and then now from the 9th batch, that the lymphomas are sometimes hard to differentiate between. Do you guys feel that?
12th and 15th, you mean?
Oh, 12th and 13th, sorry.
I love you, bro.
Just read it 50 times and it's all right. I agree with you. It's just a matter of.
The water's there.
All right, bye-bye. I agree with you. You just have to kind of read it a bunch of times until it really sticks. But sometimes I've noticed a problem, at least for me, when I was doing it for the first time, was, okay, how do I read this question and know what they're talking about when they don't really tell me about like specific cell markers or, you know, specific enzymes that stain positive, or, you know, proteins that stain positive. So we're going to go through that today. Just give me 1 second. I am opening up the questions over here, and I will share my screen immediately as soon as I have that. All right. Okay, so I'm doing something a little bit different today. So who was here with me for the pulmonology review session? Like, I think around 3 weeks back. All right. Nice. Okay, so I'm doing something a little bit different today, but I wanted to quickly ask you guys for a little bit of feedback. I sent the presentation after. If you looked at it, was it helpful, like the explanations at the bottom and on the consecutive slides and whatnot? If it wasn't, like, feel free to tell me genuinely if you want to DM me privately, just so I know like what I should add or should not add this time for you guys, because I want it to be beneficial for you. So that's the only reason I'm asking. Anytime. I'm happy to do it. Wallah, I'm happy to do it. All right, I am going to share my screen with you. So today I'm not doing a presentation per se. I made a custom review session for you guys on AMBOSS, and it has leukemias, lymphomas. What is happening? Resume share. Okay, I'm going to try that again. Can you guys see this? My, like, don't make fun of my percentage, but can you guys see this? Yeah. Awesome. Okay. All right. Okay. So I'm also doing HEM-ONC, as you can see over here. That's why I was like, I have to do the review session with them, because this is like my excuse to study. It forces me to study, and I get to hopefully help you guys. So I'm going to do a custom session. So I made a few, I collected a few questions, around 12 or 13 questions. Hopefully they will not be too slow. Here, 3rd year. Remove that. And status, all of them. Difficulty, all of them. All right. So it's 13 out of 13. Okay, so we're going to start together because I wanted to highlight with you guys and everything. Okay, so hopefully this will make it easier. Now, I did not collect them like, I did not basically put them in any order. And the reason I didn't do that is because for you guys, it's incredibly important that you know how to come to a differential yourself, again, like on your exam, because your exam is not going to tell you like, this is about a chronic leukemia. What is it? Blah, blah, blah. This is about a non-Hodgkin lymphoma. Like, they're not going to tell you, you have to figure that out on your own. And I also made a mind map for you guys. I'm going to show it to you after we do the questions. So you can kind of maybe like, if you're still having trouble, you can use that to maybe map it out in your mind. Like, okay, blood cancers, leukemias, lymphomas, Hodgkin, non-Hodgkin, blah, blah, blah. Okay, so we're going to go into that. So now for the first question, does anybody want to read, or do you want me to read it out loud? I will read it out loud. Okay. All right. Okay. So a 62-year-old man comes to the physician because of easy bruising and recurrent nosebleeds for the past 4 months. All right. During the same time period, the patient has felt weak and has had a 10 kg weight loss. Physical examination shows mucosal pallor and bruising in the upper and lower extremities at various stages of healing. The spleen is palpated 4 centimeters below the left costal margin. Lab studies show anemia and thrombocytopenia. A photomicrograph of the peripheral blood smear is shown. Histologic examination of the bone marrow biopsy in this patient is most likely to show which of the following. So let's look at this. Now, before we go and look at the important points in the question, what do you guys see in this photomicrograph? Okay, Shema said hairy cell. Anyone else? Could it be anything else? Weird looking blast, I don't know. Okay. So anyone else, or do you want to? All right, so now let's quickly go through the question. And guys, feel free to unmute, please, if you want to answer and whatnot. Okay, so age, 62-year-old man. And what are the important points in this question? Like what is something that stands out to you that you're like, okay, this is important, this is going to get me to the answer? Don't just look at what I highlighted. I didn't highlight everything important yet. Weight loss, good. Okay, so 10 kg weight loss. That's a lot in the past 4 months. Easy bruising, recurrent nosebleeds. What can that tell you? Good, Hadil. Recurrent nosebleeds, yeah. And obviously the thrombocytopenia, good. Okay, very, very good. So, and the picture is showing what? So some people said hairy cell, some people said weird looking blast. So now let's look at the options. So what are you going to find in the bone marrow biopsy of this patient? A, neoplastic granulocytes with low leukocyte alkaline phosphatase score. Neoplastic lymphocytes that stain positive for tartrate-resistant acid phosphatase. Neoplastic myeloid cells that stain positive for myeloperoxidase. Or D, dysplastic erythroid cells that stain positive for iron. Or E, neoplastic lymphoid cells that stain positive for TDT. What do you guys think it is and why? Okay, Ahmed said C. Shema and Sara said A, neoplastic granulocytes with low leukocyte alkaline phosphatase score. Okay. Anyone else? Okay, so you guys are going for A. I'm going to click on A, and if it's not the answer, we're going to redo it. Okay, so it's not the answer. So try one more time if it's not A. E, neoplastic lymphoid cells that stain positive for TDT. Okay. Huda, Walid, what do you guys think TDT stains positive in? ALL. Good. Yes, it stains positive in ALL. That's very important. Now, in this picture, is this like a picture of acute lymphoblastic leukemia? No. Okay. We need more than 20% sure. Okay. That's actually a very important point. You do need more than 20% for an acute picture. Okay. So it seems like a hairy cell, but oh, you guys didn't take hairy cell? No way. Oh my God. Okay. I'm glad I know now. I thought they gave it to you because they gave it to us. Okay, never mind. Okay. Well, guys, in hairy cell leukemia, so let's go one by one. Okay. Since you guys don't know, I'm so sorry. I did not know that they didn't teach that to you. Okay. The answer is TRAP. Okay, so neoplastic lymphocytes that stain positive for tartrate resistant acid phosphatase, okay? That is a hairy cell. Shema, good job. It's a hairy cell. I did not know that they didn't teach it to you because that's so odd. I remember probably because I had to do it for step 1 and I'm blurring what I did for step 1 with third year. I thought they taught it to you, but either way, TRAP is a positive stain for hairy cell leukemia, but let's go through the other things because you guys definitely took the other things in here. So neoplastic granulocytes with low leukocyte alkaline phosphatase score, where would you see that? Perfect, CML, good job guys. Now, what would you see in a leukemoid reaction in comparison to CML? What is the difference? Exactly, high ALP or normal ALP? It's normal to high, good job. And that is because, really important concept. It's because the leukocytes in, yes, it's because the leukocytes in a leukemoid reaction are normal. It's just in response like a viral infection or a previous infection that you've had. It looks like, oh my God, this person might have acute myeloid leukemia, but then you look at it and their lab score is normal or high, then you know, okay, no, these are normal myelocytes or whatever it is, and it's leukemoid reaction, okay? And then for CML, low because they're not functioning normally. Okay, neoplastic myeloid cells that stain positive for myeloperoxidase, where would you see that? AML, perfect, okay, good. Dysplastic erythroid cells that stain positive for iron. Perfect, Walid, sideroblasts, yeah, okay. And neoplastic lymphoid cells, TDT, you guys said it, ALL, okay? Now, next question. So is that clear to you guys, or do you want me to go over anything really quickly? Clear, awesome, okay. If one person says it, I'm gonna move. And then if you guys have a question, I'll come back to your question, okay? So don't worry about that. All right, next one. A 6-year-old boy is brought to the physician because of abdominal distension, fatigue, night sweats over the last 4 months. He has also had a 2-month history of postprandial fullness and recurrent non-bilious vomiting. He appears pale. Abdominal distension shows hepatosplenomegaly, shifting dullness, mild tenderness to palpation. Examination of the skin shows multiple non-blanching maculae. A CT scan of the abdomen shows mesenteric and retroperitoneal lymph node enlargement and nodular thickening of the omentum. A photomicrograph of the biopsy is shown of the mesenteric lymph node. Immunohistochemical staining of the Ki67 nuclear antigen shows that the proliferation index of the specimen is greater than 99%. Structure indicated by the arrows is most likely which of the following. So they gave you a bunch of stuff that you don't have to remember, and all you have to look at is this photomicrograph. Now, I'm going to show you the photomicrograph, and then we're going to go to the, what's it called? To the vignette. So here, what do you guys see in here? What does this look like generally? Okay. So I'm seeing people say owl eye read Sternberg, and I'm seeing Shema say starry sky. One of you is correct. Now let's look at the age of the patient. 6-year-old boy, he's very young. Abdominal distension, fatigue, night sweats. So these are what are, okay, fatigue, night sweats, and weight loss, typically. These are what are known as B symptoms or your constitutional symptoms, right? So that this is definitely a malignancy. You guys know from this review session, it's gonna be a malignancy in the question right now, right? Typically. So explain to me why he's having abdominal symptoms. Is this Burkitt's? Maybe. Maybe it is. But explain to me like the abdominal distension. Is that because this patient's tumor is secreting something, or is it a tumor effect? Like, what is it? Because this is an important concept that you guys do need to know generally about this type of tumor. What do you guys think it is? Okay, firstly, what type of cancer do you guys think this is? So some of you said Reed Sternberg, some of you said starry sky, and then Walid said, is this Burkitt's? Now, when you look at the photomicrograph from afar, what do you see? Burkitt's. Starry sky appearance. He's a 6-year-old boy. He's very young. The proliferation index, this is incredibly important, is 99%. That means it's very aggressive, like very, very aggressive. This is growing. Burkitt's lymphomas typically can even double within, I was asking my dad this, like a few days to even a week. It can double. So you have to treat it immediately. Now, because you guys understand this is starry sky appearance, when you look at this over here, what makes these structures over here? Basically the stars in the sky. Macrophages. Okay, so who wants to go for macrophages and who wants to go for EBV? Walid, if you were thinking what is a possible cause of this, E is definitely an answer. Yeah, exactly. E is definitely an answer, but they're asking what these specific structures are. D, good, okay, macrophage. Perfect, guys. So these are macrophages. This is basically all of these are macrophages. That's very important, not just for this exam, but also for the future for step 1, in case you guys are interested in taking that exam. All right. Okay, so HIV is also a cause, more so also of like Hodgkin's, okay? And that's incredibly important to know. Macrophages cause these like stars in the sky and your starry sky appearance, okay? In your lymph node like dissection in a Burkitt's lymphoma patient. All right. Next question. A 48-year-old woman comes to the physician because of a 3-month history of low-grade fever, unintentional weight loss, night sweats, and a right-sided neck mass. Okay. Examination shows pallor. There's non-tender and immobile right-sided cervical mass and enlarged axillary and inguinal lymph nodes. The liver is palpated 4 centimeters below the right costal margin. Spleen is palpated 3 centimeters below the left costal margin. Histopathologic examination of a cervical lymph node biopsy specimen shows a nodular proliferation of centrocytes and centroblasts that stain positive for CD20. Genetic analysis shows a reciprocal translocation of the chromosomes 14 and 18. The patient's condition is most likely caused by mutation of an oncogene that encodes for a protein involved in which of the following processes? So if you guys remember, what is 1418? Good, follicular. Good job, Walid. So translocation of chromosomes 14 and 18 causes follicular lymphoma. Follicular lymphoma is it high grade or low grade, would you say? Do you know? Low grade, good. Okay, and what is the oncogene that is involved? So some of you said it, Walid said it, Ahmed said it, BCL2. And what is BCL2 responsible for? Apoptosis, good. Specifically, anti-apoptosis, right? Good job. So let's see the other things. Hydrolysis guanosine triphosphate, nope. Upregulation of cytokine receptor binding, no. Transfer of phosphate from ATP to cellular protein, inhibition of DNA break repair, phosphorylation of serine and threonine, inhibition of programmed cell death. So you guys said it, it is F, okay? Now, do you guys know where you would see like, actually, I think there's another question, so I'm gonna wait for that, okay? But you guys got it, you guys got it correct. Do you guys have any questions about this? I'm gonna assume no. All right, okay, perfect, clear. Okay, just give me 1 second. Okay, if I said this was, one quick question, if I said this was translocation 11 to 14, what would the picture be now? Mantle, okay, good. So mantle cell. So now if I say, which of the problems here basically is occurring, what would the answer be? I don't think it's in here, but tell me what you guys would say. Okay, cool. So cyclin D1 is involved, good. So then how would that come into question? What do you think it would say? G1 to GS, good. So it's like lack of regulation of the cell cycle. Sometimes in the question, it can even say specifically from G1 to S phase. Good job, Shema. Good job, Ahmed. Good job, the people who said mantle. So is that clear? Like the question can come like that. And in our exam, I remember, I think it came like that once, if I'm not wrong. So do remember that, like know the, number one, the translocations, usually it's a matter of memorizing them. Knowing what proto-oncogene or oncogene is related to that and like what's dysregulated basically, and what that means, okay? And that can even kind of help you in understanding if something is more high grade or low grade, okay? Now, next question. A 6-year-old man comes to the physician because of a 2-month history of chest pain, dry cough, and shortness of breath. He describes 2 painless masses in his neck, which he says appeared 4 months ago. So 2 months history of chest pain, dry cough, and shortness of breath. 2 painless masses in his neck appeared 4 months ago and are progressively increasing in size. So it's painting a picture of malignancy. During this time, he has had week-long episodes of fever interspersed with 10-day periods of being afebrile. He reports that his clothes have become looser over the past few months. He drinks alcohol occasionally. His temperature is 38, pulse is 90, BP is 105/60, nothing out of the norm, except his temperature. It's high, right? Fever is very important. It's part of your B symptoms, AKA your constitutional symptoms. Your constitutional symptoms are fever, drenching night sweats, and weight loss, okay? Like fatigue, drenching night fever, fatigue, drenching night sweats, and weight loss. Drenching is a very important word, by the way. Like some people can be sweating at night just because it's hot in their room, but you have to ask them, like, are you basically soaked when you're up in the morning? Or like if you wake up in the middle of the night, are you soaked? All right. Physical examination shows 2 non-tender fixed cervical lymph nodes on either side of the neck, approximately 2.2 and 4.5 in size. The tip of the spleen is palpated 3 centimeters below the left costal margin, and an X-ray of the chest shows discrete widening of the superior mediastinum. Which of the following is the most appropriate to confirm diagnosis? Now, this is not asking about what the exact diagnosis is, but this is very important for understanding. Okay, so Huda and Sara said, and Suad said G, excisional biopsy. Does anybody have any other answer? I guess nobody has any other answer, so let's go for G. So leukocyte count, why not? It doesn't confirm the diagnosis, right? Like it'll tell you like, yeah, there's a problem, but it doesn't confirm what diagnosis is. Fine needle aspiration, you never do that. Never ever do that we literally learned this last week and we were doing our HEM-ONC rotation. You never do a fine needle aspiration for a lymph node that is giving the picture of malignancy. Sputum polymerase chain reaction test, that's not going to give you much for the diagnosis. CT scan of the chest is going to tell you that there's maybe a mass, but it's not going to tell you which mass exactly, what the mass is made of. It's not going to tell you the exact answer. Viral serology can tell you the cause, but it's not going to tell you the diagnosis. Bone marrow aspiration, not going to tell you much. It's just going to tell you like the picture of what's going on. For example, is this patient anemic? If they are anemic, is it aplastic? Do they have, polyclonal, monoclonal proliferation, etc., but it's not going to give you the final diagnosis. So you guys are right. G, excisional biopsy. Okay, so this is to distinguish between Hodgkin's versus non-Hodgkin's lymphoma because they can present similarly in some cases, in most cases actually. All right, so good job, excisional biopsy. All right, so 16-year-old boy is brought to the physician because of a lesion that has been growing on his jaw for over the past several months. So immediately when you see this, what is ringing in your head? Burkitt, good. This is one of those words where it's like ding, ding, ding. Okay, Burkitt, it's like jaw. You're not really going to see much else there, honestly, unless it's like a head and neck problem. Okay, he recently emigrated to the USA from Kenya with his family. Obviously, questions like these sometimes, they will focus on a certain demographic. So specifically in this demographic, it can be a little bit more common. Physical examination shows a 3 centimeter solid mass located above the left mandible. There is cervical lymphadenopathy. Biopsy of the mass shows sheets of lymphocytes and interspersed reactive histiocytes with abundant clear cytoplasm and phagocytosed debris. So what were those things? What are the stars in the sky? What are they made of? Quick review. Macrophages, good. Good, Ahmed, macrophages. So which of the following mechanisms is most likely directly responsible for the malignant transformation for this patient's cells? Okay, so A, activation of transcription, B, defect in DNA repair, C, impairment of receptor function, D, inhibition of apoptosis, E, inhibition of cell cycle arrest, or F, integration of viral DNA. Okay, so Ahmed said A, MYC, like CMYC. Walid said CMYC as well. Does anybody else have any other answer? I'm going to assume no, so let's go for A, activation of transcription. Good job. So Burkitt lymphoma is translocation what? Good, good, Shema. 8 to 14. T starts at 14, yeah. 8 to 14. And it is overexpression of the c-MYC gene, which is responsible for transcription activation. Good job, guys. So let's just say now I asked you what, okay, the answer D, inhibition of apoptosis. That would be the answer to what, like, clinical vignette malignancy? BCL2, follicular lymphoma. Good, okay. And then what is the translocation for follicular lymphoma? We just did it. 14 to 18. Good job. 14 to 18. Okay. And then if I asked you about E, inhibition of cell cycle arrest. Mantle, good. Good. Mantle. And mantle is translocation? 11 to 14. Very good. You guys are good. Well, you don't need this review session. You guys know everything. Do you guys have any questions about this one? Anything that you want to like open up over here? Is there any that you want me to open that you can read? Otherwise, by the way, I'm gonna share this custom study session with you guys later if you guys want to go through the questions again yourself, and I'm gonna share a presentation with you as well, okay? So don't worry about that. All right, okay, next question. Let me just see what number we're on. Okay, we're on 6. Good, okay. A 55-year-old man comes to the physician because of a 3-month history of progressively growing mass in his axilla. During this period, he's had recurrent episodes of low-grade fever lasting for 7 to 10 days and an 8 kg weight loss. So there you go. Those are your constitutional symptoms. Okay, two out of 3 of them. Okay. His only medication is a multivitamin. Examination shows non-tender right axillary cervical and inguinal lymphadenopathy. His serum calcium concentration is 15.1 milligrams per deciliter, and parathyroid hormone concentration is 2. Let's look. I'm going to show you guys the labs to see if that's normal or not. Okay. A lymph node biopsy shows granuloma formation and large CD15 and CD30 positive cells with bilobe nuclei. What is ringing in your head already when you see this? Reed Sternberg, good. And what is that pathognomonic for? Which type of lymphoma? Perfect. Hodgkin lymphoma. Very good, guys. So which of the following is the most likely explanation for this patient's lab findings? So this is more about, is it Suad? Is it? Let's see. Okay, some of you are saying C. So basically, the question is asking about why does this patient have high serum calcium? And let's see the parathyroid hormone. Let's open that together. PTH. Here you go. Where? Yeah, PTH, 10 to 60. So it's really low, right? It shouldn't be 2. That means that the PTH itself is not working. Like it's not coming from the parathyroid itself, right? So you guys are saying, so Suad said E, production of PTH-related peptide by malignant cells. And Ahmed and Huda said C, induction of focal osteolysis by tumor cells. Does anybody else have any other choices that they want to choose? Wait, won't this be in multiple myeloma? Yeah, or not only. Sometimes, for example, when you have like a malignancy and it's progressing, you can have, like to answer your question, you can have hypercalcemia in multiple myeloma, yes. But the option C, yeah, that can happen due to that in multiple myeloma, yeah. So do you still want to go with C? We can click C and you guys can see if it's the answer or not. I'm not going to tell you until you guys get it. So let's go for C. No, right? So osteolytic bone metastases, usually when you have bone marrow infiltration or in multiple myeloma, it's basically, its home is the bone marrow. Typically going to get lower back pain because that's where weight bearing is. And you're going to get hypercalcemia because you also have bone resorption locally over there. Okay, focal osteolysis. So focus like bone resorption. So what other option do you guys want to go for if it's not C? So Suad said E. You guys want to go for E, production of PTH-related peptide by malignant cells. Okay, we can go for that. But it's not the answer because you will get PTHRP typically in other paraneoplastic syndromes. So you'll get it, for example, in squamous cell carcinomas of the, oh, it's right here, yeah. squamous cell carcinomas of the lung, head, and neck. So typically in a squamous cell carcinoma, but this is not giving that picture. So this is a harder one, definitely, but it's an important concept because it ties back to other things. So Sada said D then. So let's go for D. Good job. The answer, none of the above. No, it's a secretion of gamma interferon by activated T lymphocytes. So basically in Hodgkin's lymphoma, you can get a paraneoplastic symptom of like hypercalcemia, and it's due to increased vitamin D activation. You're going to have more active vitamin D, okay? So in active T lymphocytes that surround Reed-Sternberg cells, they're going to secrete gamma interferons. And what these do is they basically go to malignant lymphocytes and specifically macrophages. The reason I put this question in here is not only for your exam. It might come on your exam, but maybe not. I don't think they're going to go this in depth because Dr. Rehan cares about you guys. So I don't think he's going to ask you this specifically. But I brought this because it's important to know what is causing which paraneoplastic syndrome, because they are going to come throughout the year, number one. And number two, for Hodgkin's, I need you guys to understand this. So you have your Reed-Sternberg cells. It's surrounded by T lymphocytes. These T lymphocytes basically call the macrophages and other things to start acting up, right? Because they secrete gamma interferon. So macrophages have 1-alpha hydroxylase. Now, forever who attended my pulmo session, I remember I said this. In sarcoidosis, for example, you have a lot of macrophages and you have hypercalcemia. Why? It's the exact same mechanism, because you have increased expression of 1-alpha hydroxylase. So this is something that's in macrophages. So anytime you see something where you don't know the specific paraneoplastic syndrome where it causes hypercalcemia. So for example, Huda said in multiple myeloma, it's focal osteolysis. That was correct. In squamous cell carcinoma, it's PTH-related peptide. Good. For example, in sarcoidosis, in Hodgkin's, for example, you're like, why is there hypercalcemia? You have to think about this, okay? Because obviously there's a lot of immune cells involved. So that's probably what's causing it. Do you guys have any questions about this? This is an important concept for upcoming exams and also for step one, by the way, if you do plan on taking step one. The reason I say that a lot is because I did it and these questions came again and again, especially in practice. So T cells increase macrophages, causes activation of vitamin D. Basically, Ahmed, yes. So the T cells around your Reed-Sternberg cells, they're like T cells do this thing where they secrete gamma interferon, right? Like you need to do that anyway. But it's happening at a higher rate because this is a lymphoma, right? Like they're going crazy. So they have more gamma interferon, and that gamma interferon basically activates macrophages, specifically increases 1-alpha hydroxylase activity in macrophages. And 1-alpha hydroxylase is responsible for activating vitamin D. Does that make sense? That's like to give you in detail. Awesome, perfect. Sorry, did not mean to open that. Okay. Yeah, so cool. Next question. If you guys have any questions, please feel free to ask and I'll get to them, okay? So 52-year-old woman comes to the physician because of a 6-month history of generalized fatigue, low-grade fever, and 10 kg weight loss. They're your constitutional symptoms. What else is important? Her age, 52. Physical examination shows generalized pallor and splenomegaly. Hemoglobin is 7.5, so that's low. Leukocyte count is 41,800, that's high. And lap activity is low. Immediately, what is ringing in your head? Good, CML, perfect. Low lap score CML, normal to high lap score, leukomoid reaction, okay? That's how you differentiate them. Peripheral blood smear shows basophilia with myelocytes and metamyelocytes. Bone marrow biopsy shows cellular hyperplasia, with proliferation of immature granulocytic cells. Immature granulocytic cells, you know, it's myeloid origin, right? So which of the following mechanisms is most likely responsible for this patient? So Hadil said E, Shema said E, anyone else? Suad said E, good job guys. Walid said E, all right. So let's go for E, good job. Unregulated expression of the ABL1 gene. So tell me in CML, what is a translocation? Perfect, 922, translocation 922. And what do you call that chromosome now? After the translocation, Philadelphia chromosome. And what fusion protein does it make? BCR-ABL, perfect. Okay, and what does this fusion protein do? What activity is increased? Guys, you're so good. You don't need this review session. I mean it. You guys know everything important. So tyrosine kinase, perfect. So one more bonus question then, I guess, because you guys know everything like up until now. What is, you answered it before I asked, yes, imatinib. So what is the treatment of choice? Tyrosine kinase inhibitor. So imatinib, dasatinib, nilotinib. Good job, guys. You guys are great. Okay, so tyrosine kinase inhibitors. Okay, you know what? Another bonus question really quickly. Rituximab, imatinib. What is the difference between ab and ib? Important concept in life and medicine. You guys probably know this. Dr. Dehan probably. Okay. So which one is a monoclonal antibody? Good job, Shema. So ab is antibody. When you see ab as an ending, antibody, okay? Ib, inhibitor. That's all you need to know. Rituximab specifically, yes, Walid, it is anti-CD20, okay? Ib is small molecule inhibitors. Good job, guys. Mashallah. You guys are great. Okay, next question. Easy. 11-year-old boy, immigrated from Nigeria, brought to the physician with evaluation of jaw swelling. What's ringing in your head? Nothing new. Tayyib, say Burkitt's first. Okay, good. Burkitt's, yes. So 5 centimeter solid mass, blah, 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 mandible, cervical lymphadenopathy, biopsy mass, lymphocytes interspersed, macrophages, cool. EBV positive serology. You guys guessed it, yes, it's Burkitt's, and the translocation is, like you guys said, E, translocation 814. Okay, now 922, quickly, what is that? Let's go through the options. Good, CML. 1122. I know you guys didn't take it. I just wanted to see if anyone knew it. It's Ewing sarcoma. You guys are going to learn this in MSI, okay? 11 to 14. Mantle, good. 14 to 18. Follicular, perfect. 12 to 21. ALL, okay? ALL. This one is, did they teach you guys, just so I know, did they teach you like translocation, this has a poor prognosis versus this translocation has a good prognosis for ALL, AML? Did they teach you guys this? I remember we got one lecture, but we weren't tested on all of them. Okay, so you guys did learn it. Okay, then pop quiz. AML, acute myeloid leukemia. What translocation gives you a poor prognosis? Just give me one. There's like one main one. 5-7. 5-7 is one of them, I think. Yeah, but I'm thinking of another one. Q11, okay. I honestly don't remember. There's one specific one I'm looking for. It is a translocation for another cancer we just spoke about, but for that one, it doesn't matter. But for this one, in version 16 also it does exist, yeah. That's also, I think it has a poor prognostic factor, yes. Basically for AML, one of the poor, yes. AML or ALL? Shema. Oh, is it ALL? Oh, I'm sorry, my bad. Okay, ALL and not AML. But either way, T922 is CML, right? If you see that translocation otherwise, it's a poor prognosis. But in CML, like you're chilling. You just give imatinib. Hopefully as chronic therapy, it works like as continuous therapy. But that's the one I wanted to pull out of you guys. Sorry, I thought it was AML. I didn't realize it was ALL. I have to go check that out myself really quick. Okay, next question. Oh, sorry, last one, T15 to 17. APL, and what's the treatment? Atra, all transretinoic acid, perfect. And pathognomonic, like you're gonna see it in the blood smear. What are you gonna see? You can also give arsenic. Yes, Ahmed, they used to give arsenic before, now they opt for Atra. Multiple ARADs, perfect. Guys, you guys know everything. Many ARADs, good job, guys. Okay, next question. So, 71-year-old man comes to the physician for routine health examination. He has occasional fatigue, but otherwise feels well. He has a history of hypertension and type 2 diabetes. He's a retired chemist. His only medication is Ramipril. What is Ramipril? You guys took CVP. Good, ACE inhibitor. Temperature is 37.8, pulse 72, respirations are 18, blood pressure 130/70, nothing out of the normal, except maybe his temperature is slightly high. This is like an incredibly low grade fever, okay? Not incredibly low grade, it's just like a low grade fever. I shouldn't say incredibly. Okay. Physical examination, non-tender cervical lymph node, cervical and axillary lymphadenopathy. So non-tender should ring a bell for you, like, okay, we got to look out for possible malignancy. Spleen is palpated 7 centimeters below the costal margin. So you guys have been seeing this in every question almost. Spleen or liver palpated below the costal margin. Why is that important? Hepatosplenomegaly, but why is that important? Like, what does that mean? Why are they having it? Good, hyperproliferation. Also in the spleen, sequestration can occur. Extramedullary or sequestration, good, Shema, yeah. Also just hyperproliferation, it can go and like sit in your spleen and liver basically sometimes. Or like you said, extramedullary proliferation or hematopoiesis or sequestration, okay? Now, spleen is palpated, yeah, okay, cool. Leukocyte count is 21,000 and platelet count is 210,000. Is that normal, the platelet count? Yeah, good. 150 to 400,000 is normal, okay? Or 450,000. Further evaluation is most likely to show which of the following. So what is this giving the picture of? Is this an acute or chronic picture? Or is this like a high grade or low grade picture? Chronic, okay. Leukemia or lymphoma? Okay. Let me re-ask that question. Myelocytes or lymphocytes? Is this like myeloid or lymphoid? Probably leukemia. So I will tell you guys this, it is leukemia, but is it myeloid or lymphoid? Myeloid, okay. Lymphoid, you can probably tell from my tone. Can we see CBC? You mean like the labs? You can open the labs if you guys want. I don't know what you want to look at exactly though. Here you go if you want to look at the blood. So normally it's up until 11,000, right? But this is 21,000, so it's obviously increased. But either way, further evaluation is most likely to show which of the following. So keep in mind the patient's age, chronic, low-grade fever, E, smudge cells. Okay, so Shema, okay guys, so where do you see smudge cells? Chronic myeloid leukemia, chronic lymphoid leukemia, CLL, good. Okay, so I'm gonna go for smudge cells and you guys are right. So these are smudge cells. Can you guys see these? Do you guys know how smudge cells occur? If you don't, it's okay, I can tell you. Basically, they're just very, very fragile lymphocytes. Exactly, Shema. So they're really fragile, so they get smudged in the peripheral film. Exactly, that's literally it. So these are very pathognomonic of CLL, okay? And what is typically positive in CLL? Like marker, CD marker, typically. Not always, but typically. TFT, TDT, okay. Another one. I think TDT probably in CLL, but it's more specific for ALL. Like it's very, very, at least for when you study step 1 and whatnot, TDT is always brought up in the context of ALL. Even they're both lymphocytic leukemia. CD, I wanted to hear CD20. So CD19, CD20, right? Because it's typically CLL is B cell proliferation. And that's important to know because in your treatment plan for CLL, you typically also add rituximab. It's almost always added, especially in like B cell neoplasm. So even in some non-Hodgkin lymphomas, etc. If it's CD20 positive, you will add rituximab. There's a lot of randomized controlled trials where adding rituximab had a better, like patients had a better response and like course of treatment and whatnot, as opposed to patients who did not take rituximab, which is anti-CD20, right? So it's typically used in the regimen for CLL. That's why I wanted to bring that up. All right, good job, guys. Smart cells. Where would you see rouleau formation? Huda mentioned it earlier. Multiple myeloma, good. Okay, hypergammaglobulinemia. Also multiple myeloma, okay? It's a diagnostic marker for multiple myeloma. You remember, you're gonna see that M spike, monoclonal M spike. Teardrop cells, where are you gonna see that? Myelofibrosis, perfect. Smut cell, CLL, polycythemia, you're gonna see in, well, polycythemia vera, right? All right. Next question, how many do we have? I hope we finish. We got 4 more. I think we can finish, hopefully. I'll need until like 7:05, max 7:10, but inshallah we'll finish before that. So 67-year-old woman comes to the physician because of 3-week history of fatigue, worsening back pain, and abdominal pain. During this period, she has also had excessive night sweats and 4.6 kg weight loss. She has had a swelling of the neck for 3 days. She does not smoke or drink alcohol. Vital signs are within normal limits. Physical examination shows a 4 centimeter supraclavicular non-tender and large and fixed lymph node. Spleen is palpated 2 centimeters below the left costal margin. Lab studies show hemoglobin of 10.4. Mean corpuscular volume of 87. Is that normal or high or low? Normal, yeah, good job. Okay, leukocyte count 5,200. Platelet count 190,000, and her serum lactate dehydrogenase is 310. Is this high or low? What is the importance of lactate dehydrogenase? There's more than one, I would say. Hemolysis is number 1, and you guys, I think, just took that with Maryam. Number 2 is because tumor cells like to use lactate for their own like anaerobic metabolism, because they don't require so much oxygen. That's what makes them grow. So it's like the Warburg effect, if you guys learned about that. Lactate dehydrogenase is a good, it's a good teller in your lab of your tumor burden. So that's another use for lactate dehydrogenase, okay? So CT scan of the thorax and abdomen show massively enlarged para-aortic, axillary, mediastinal, and cervical lymph nodes. Girl. Histopathologic examination of an excised surgical lymph node shows lymphocytes with a high proliferative index. There you go, high proliferative index. It's stained positive for CD20. What is the most likely diagnosis? So it's giving high-grade picture. It's giving high-grade picture. B, okay, so you want to go for DLBCL, Shema. Anyone else? Diffuse large, okay. No one want to go for hairy cell, follicular, Hodgkin, adult T cell. Why not adult T cell? What is the immediate no? CD20, good. So let's just take that out. Not that. It is yes, Walid, it is the most common along with follicular. Good. So in this woman, and also given the location, given the lymph nodes that are specifically affected, let's go for DLBCL and see if it's the answer. Yes, it is. Good job. So DLBCL. Okay. So high grade, number 1, DLBCL is high grade. Fun fact, I just saw a patient actually last week in our rounds, 16-year-old girl. She had a DLBCL and she was getting treatment for it. Did they teach you the regimen? Do they teach you guys a regimen for these cancers like DLBCL? Rituximab is part of it. It's definitely part of it, but it's not the whole. So basically, I don't know if they teach this to you, so I kind of don't want to tell you because I don't want to overwhelm you in case you guys don't need to know it. So I won't, but rituximab is part of it, okay? But you basically use R-CHOP. It's literally right here, R-CHOP. So R is rituximab, and you guys can see it here, actually. I'll just read it out to you. You do need to know this in 5th year, but I don't think you need to know it for you guys, but if in case you do want to know. Where did it just go? Okay. Here you go. There you go. Rituximab, cyclophosphamide. You can use doxorubicin or hydroxydaunorubicin, which is H. So rituximab, cyclophosphamide, doxo or hydroxydaunorubicin, vincristine, aka oncovin, and prednisolone. Okay. I know you guys took ABVD for if I'm not wrong, Hodgkin's. Please correct me if I'm wrong because I also forgot So you did take them. Okay, good. So rituximab is, again, CD20, you're going to add rituximab to their treatment regimen. So if you guys are unsure, for example, of like a answer, and you know, like this is a CD20 positive tumor, if you see an answer with rituximab, go for that one. If it's alone, don't go for that one. But if you see it with other things, go for that one if it's like the only answer choice. All right. Now, next one. Quickly. 19-year-old man comes to the physician because of evaluation night sweats, pruritus, enlarging masses in the right axilla, supraclavicular area for 2 weeks. Painless rubbery lymphadenopathy, right axillary, supraclavicular, and submental regions. Excisional biopsy is performed. If present, which of the following features would be most concerning for neoplasm? So for a neoplastic process, what do you guys think? Shema said C. Okay, so preponderance of lymphocytes with a single immunoglobulin variable domain allele. This question is a little bit more challenging, so don't worry if you don't know it at the top of your head or something. It's more for concepts, like it is important. It's important for your understanding for the exam. So Shema said C. Does anybody have any other answer that they want to go for? Okay, I'm guessing no. So let's just quickly go through them together. So polyclonal when will I get this word right? Proliferation of lymphocytes with a single nucleus. Does that sound like cancer to you? Like, does that sound scary? No, right? So I'm gonna take it out. So abundant lymphocytes in a wide range of sizes and shapes in medullary cords. Is that worrisome? And then there's C, which Shema mentioned. So then D, positive staining of the paracortex for cluster of differentiation 8. No, right? Diffuse mitotic activity in secondary follicles, predominance of histiocytes in the medullary sinuses. Since no one else answered, let's go with Shema's answer, which is C, and let's see if that's correct, okay? Good job, Shema, it's C. So let's explain this a little bit. So preponderance of lymphocytes with a single immunoglobulin variable domain allele. Typically, when you make immunoglobulins, you want polyclonal proliferation. You want polyclonal proliferation, right? Because you want your antibodies to be able to attack this virus, that bacteria, start going and attacking that fungus, I don't know, whatever, right? Specifically viruses and bacteria most of the time, right? You're also going to have like antifungal, you know, antigens and whatnot that they're going to act against. But you want them to be able to do that, right? If you have a single immunoglobulin variable domain allele, that is very concerning because it's like, you call that restrictive gammopathy. And that is sometimes, that's basically what happens in multiple myeloma, for example, right? So if you see that, that is very concerning for malignancy, like a neoplastic process is occurring. Any of these other things, they can normally occur in your lymph nodes, right? They're always making new, like lymphocytes are, you know, they're dividing, they're making different antibodies. You do have positive staining of paracortex for cluster of differentiation 8. You do have diffuse mitotic activity in secondary follicles. So this is the one thing you want to look out for to say, yes, this is most likely showing a malignant picture or neoplastic picture. Lymphocytes with a single immunoglobulin variable domain allele. Okay, so any questions or move on? We have, I think, 2 more questions and we're done. I'm going to assume no, and I'm going to go to the next one. All right. Okay. So 51-year-old man comes to the physician because of a 4-month history of fatigue, increased sweating, and 5.4 kg weight loss. Over the past 3 weeks, he's had gingival bleeding when brushing his teeth. 20 years ago, he was diagnosed with a testicular tumor and treated with radiation therapy. His temperature is 37.8, so he has a low-grade fever. Pulse is 70, respirations are 12 per minute, blood pressure is 130/80, normal. Because also he's like 51, so that's normal for him. He takes no medications. Cardiopulmonary examination shows no abnormalities. The spleen is palpated 4 centimeters below the left costal margin, so splenomegaly. Hemoglobin is 9, slightly low. Mean corpuscular volume is 86, somewhat normal. Leukocyte count is 110,000. That's a lot. Segmented neutrophils are 24%, metamyelocytes are 6%, myelocytes are 34%. So what do we say about myelocytes, myelocytes above 20%? Typically acute, right? Maybe. Let's read the rest of the questions. So promyelocytes 14%, blasts 1%, lymphocytes 11%, monocytes 4%, eosinophils 4%, basophils 2%. Platelet count is 650,000, so that's slightly high. Thrombocytosis. Yes, Huda. ALL is more in kids. AML is more common in adults. Yes. So molecular testing confirms the diagnosis. Which of the following is the most appropriate next step in treatment? Don't blasts have to be greater than 20? Yeah. Yes, Hadil, it is CML. Good on you guys for pointing that out, because that can be a little bit tricky sometimes, right? Vitamin A, why? Does this, okay. Vitamin A, though, it is a treatment for APML, promyelocytic leukemia, but I wouldn't say that here. So what do you guys think this is? If you think it's CML, sure, we can try imatinib if it's CML, right? So let's see. Good job. Imatinib is the answer. So CML, like Ahmed pointed out, blasts have to be more than 20 for an acute picture. This patient does not have more than 20% blasts, but they do have 34% myelocytes, 6% metamyelocytes. So this is important, okay? You have to compare these numbers together, especially blasts and these, okay? Because you can't see like myelocytes 34%, you're like, oh, it's above 20%, because I was doing that to see if anyone would notice, right? Blasts 1%. That means it's chronic, okay? Next question. I'm not going to go through these individually because there's too many and we're running out of time. But imatinib is the answer because it is CML, okay? So is this the last question? It is the last question. Awesome, perfect. Okay, immediately. What is this? Cool, see? But what is the photomicrograph? Cool, read Sternberg cells. Good job. Okay, so let's just quickly read the vignette, even though we probably don't need to. But 53-year-old man, 6-month history, recurring fever, night sweats, fevers persist for 7 to 10 days and subside completely for about a week. Do you guys know what this is called, this type of fever? It's pathognomonic for Hodgkin lymphoma. Not only, it's not pathognomonic, like it doesn't only happen in Hodgkin's, but it does happen in Hodgkin's. Like if you see this, like you do have to think of Hodgkin in your like differential. It's called the Appel-Epstein fever, where it basically goes like this. Like for a few days, it's like this and it like subsides. Then a few days more, it's like this and it subsides, okay? So during the past 6 months, 8 kg weight loss, noticed painless lumps on his neck, so non-tender lymphadenopathy. Severe sore throat and fever, was diagnosed as infectious mononucleosis, so EBV, which is a risk factor for Hodgkin lymphoma, where you see read Sternberg cells. He has smoked a pack of cigarettes daily, etc., does not drink alcohol, blah, blah, blah. Does monthly international travel, cool. 39 degrees, 22. I'm not gonna, this is too long. But which of the following additional findings is most likely present in this patient? You all said it. CD1530 positive cells. You see CD1530, Hodgkin lymphoma, read Sternberg cells, and you're going to see this in your photomicrograph, these owl eyes, okay? Know these things in every single exam to come in 3rd year. And I even said this in my pulmo session. You guys are just going to have to pick up on these specific words and phrases, piece them together and know this is the answer and this is how I know it because these go with these, okay? You guys were able to do it literally all throughout the session, so I'm not even worried for you guys. And that was it. Good job, guys. You got 100%. You guys are ready for your exam. Before you go really quickly, last thing, I want to quickly show you guys one thing that I made for you. I'm not completely done with it, but I wanted to show it to you just for your own. Please load. Awesome. Okay. Just really quickly. Okay. I made this mind map. I'm not completely done with it because I do want to add a few more things to the ends over here and here. But can you guys see this? Yes, okay. So I made a little mind map for you guys, basically blood cancers. So we go into leukemia, lymphoma. So lymphoma originate in the lymph nodes, leukemia originate in the bone marrow. And then you guys are pretty good at your leukemias, right? I think they're a bit more clear than lymphomas, in my opinion, when you're at least first learning them, right? You have your myeloid and lymphocytic, and then you have your acute and your chronic, and they both have their own things that they stain for, that they're features that are pathognomonic for them. And then on the lymphoma side, please scroll. You have Hodgkin and non-Hodgkin, and we just said it. Hodgkin, Reed-Sternberg cell, CD15, CD30 positive. Lymphocyte rich, there's more lymphocytes, so you're not like, that's good prognosis. There's not many lymphocytes, that's worrisome, that's a poor prognosis. In non-Hodgkin, you have your B cell and T cell. Now, I don't know, the reason I'm showing this to you guys is because, for example, you told me you didn't learn hairy cell, right? So what from here did you not learn? That's what I want to know, just so I don't include it for you guys and freak you out. I might keep it in there anyway, and you guys just pay attention to what you learned, because I'm going to share this with you guys, and I'm going to share it with my 5th year friends. You didn't take Walden. Okay, cool. Anything else? Everything else you took, right? Except obviously hairy cell, you didn't go in depth. Awesome, perfect. Okay, then I'm going to share this with you guys, and I'm also going to write down some treatments. Okay, and I'm going to share this with you guys, and inshallah it's helpful. If you guys have any feedback or anything, if you guys need anything specific, let me know. And I will also share those questions on presentation format with you, with a few things that I just want you to remember for your exam, like a few key points. All right, thank you guys so much. And if you guys need help with anything, please feel free to contact me. I'll send my email and whatnot to your BLCs or to.
Thank you so much.
Thank you. And sorry for going over time. I couldn't help it. All right. Thanks, guys.